and the localization of all lesions in nutshell. Now I invite Professor Dr. Rajini Madam for her talk on acute concomitant esotropia. She is head of the Department of Ophthalmology Department, Government Medical College, Thrissur, and she is one of the senior most professor in our medical education department. Over to you, madam.
A very good morning to all. At the outset, let me thank the KSOS Scientific Committee Chairman and Dr. Rekha for giving me this opportunity. As you all know, during this COVID period, we come across a group of patients who presented with diplopia, with normal ocular movements, and I am going to talk to you about that. So the earliest anecdotal reference is credited to Berrien and Miller, and it is a concomitant non-accommodative esotropia with acute onset presenting with diplopia, and there is a very good potential for normal binocular single vision, and surgical outcome also is very good, and there is no tendency for spontaneous resolution. There are subtypes are like this. There is a Swan type, occurs after a period of interrupted binocularity, and Franchetti type, where the patient has got a minimal hypermetropia and large angle, often associated with psychological and physical stress, and Belchowski's type, seen in myopes, and this is the commonest type which we come across in COVID time, because every other child was forced to use online classes and mobiles. So it's associated with excess near work and convergent spasm. And less common varieties are the refractive accommodative type, which is controlled with refractive correction alone. And next is the intracranial pathology, which you have to keep in mind in every case. So evaluation should start from the history and the anterior segment and assessment of binocular single vision. A photographic evidence of previously aligned eyes will give you a very good clue. So if you have the history of acute onset of concomitant esodiviation with presenting with diplopia, older children, full extraocular motility, and large angle squint with photographic evidence of previously aligned eye, make a diagnosis of acute acquired concomitant esotropia. So influence of near work is well documented. Probably the convergence force was significantly greater than the divergence force, and you have to differentiate it from the sixth cranial nerve, cyclic esotropia, divergence insufficiency, refractive esotropia, spasm of near reflex, and myasthenia. All patients should have imaging done, because 6% risk of an underlying neurological disease, especially intracranial tumors, mainly of the cerebellum or brainstem, pituitary, corpus callosum also was reported. Or you should look for evidence of hydrocephalus in imaging, and thalamic and pontine glioma. And if the patient is in the older onset and recurrence of acute concomitant esotropia, you think of intracranial cause. So there is no optimized protocol established till now to treat this condition. Your spectacle correction, if there is an accommodative component, or base out prisms to maintain binocularity till the deviation stabilizes. Botox, yes, it's a viable option to maintain binocularity during the waiting period to offset troublesome diplopia. And surgery is indicated after waiting period of 3 to 4 months of spontaneous recovery. And concern is the possible development of suppression. You have to manage these patients with prisms, Botox, and finally surgery. Prisms are feasible only in small deviations and till the deviation stabilizes, you think of giving prisms. Botulinum toxin in our setup, the cost is the main problem. A 100-unit vial, which is showed to you by Dr. Amrita, that costs around 23,000 rupees. So only if you have a group of patients to be injected, that is a viable option, and the dose is calculated depending on the amount of deviation. And ptosis is the commonest problem. There are so many reports in the literature which showed the efficacy of botulinum as good as the surgical outcome. And I'm sharing 5 cases in our experience. This is one case, a 12-year-old boy, presented with 1 week duration of binocular diplopia. He had a large angle, extraocular movements were normal, stereopsis was gross, vision was normal, imaging was normal, fundus examination also was normal. In our series, all 5 patients had similar findings of large angle, normal extraocular movements, normal vision, normal fundus, and normal imaging. And he was treated with botulinum toxin last week. The results we are just awaiting, but he shows minimal ptosis now. The surgical correction is depending on the amount of deviation, unilateral or bilateral, symmetric recession of medial rectus. All our patients underwent bimedial recession. I'll show you the results. This is a patient who is a 15-year-old boy, 4 weeks duration of acute onset of binocular diplopia. 60% diopter esotropia was there. As I already told you, the extraocular movements were normal. There was no suppression. Stereopsis was normal. Vision and fundus and imaging was normal. This is the pre-op and post-op picture of that patient. This is another patient we operated, 10-year-old boy, 1 week duration of binocular diplopia. We had the similar findings of normal ocular movements, and fundus and vision and imaging was also done in all patients. This is the pre-op and post-op picture of this patient. This is another patient, little older patient, and he had a 45% after esotropia. We had all normal extraocular movements, vision, fundus, and imaging. This is the pre-op picture and the post-op picture. And this is the youngest of the lot, who presented with a binocular diplopia. The extraocular movements were normal. It was a concomitant one. Fundus, vision, and imaging were normal. This is the pre-op and post-op picture of this patient. So, in acute acquired concomitant esotropia presents with sudden onset of diplopia in older children usually, who had previously aligned eyes, and excessive near work and stress plays a major role, and non-accommodative concomitant variety, and the ocular movements are always full, and all patients should have an imaging done and wait for at least 4 months before surgical intervention, and good surgical outcome in our experience. Thank you so much for your patient listening.
Thank you, madam, for that wonderful talk with many practical